I want to get into maybe a little more detail looking at the clinical trials, because this is just kind of a race to get approval, and I think it's pretty much inevitable. So currently there's kind of 4 big categories, and we'll see that the JANUS kinase inhibitors seem to be the leaders, but there's the PDE4 inhibitors, which Dr. Silverberg sort of touched on, the JAK inhibitors. There's these SHP1 activators and the CRTH2 molecules. And you can see here all these are kind of for the most part, in phase 2, although there's been at least one that I know of, JAK inhibitor, that's now moved on to phase 3. So because I know yesterday we had sort of a show of hands and not everybody here was dermatology and might not be completely familiar with these endpoints, most of these in the clinical trials are the EASI score. Oh yeah, you forgot to give it to me. Which measures the extent and severity of the atopic eczema. The EASI 75-90. This IGA score, which we've heard maybe isn't the best score, but it's a 5-point scale used to measure the severity of disease. And then there's this NRS, the numerical rating scale, so the pruritus scale. In most of these studies we're going to go through here quickly, the endpoints and outcome measures are one of these. The other thing I just wanted to touch on for people that aren't familiar looking at these clinical trials are the adverse events. So they classify them basically as serious or severe. So serious meaning that in view of either the investigator or the sponsor, there's outcomes that result in death, obviously, life-threatening adverse events, inpatient hospitalizations, or prolongation of an existing hospitalization. And then the severe ones are on a scale. So it's a graded scale. There's mild, there's moderate, and there's severe. And these are the big reporting outcomes that they measure. Are they a serious or are they a severe event? So we've already seen this exact slide earlier today, but this is the mechanism of the PDE4 inhibitors. So we know in atopic dermatitis, PDE4 is upregulated. And PDE4 is involved in regulating, actually downregulating degradation of cyclic AMP. So in an atopic patient, we have this increased PDE4, decreased cyclic AMP, which then activates the PKA, and we have this sort of uncontrolled inflammation. If you inhibit the PDE4, you can increase the cyclic AMP and activate PKA, and then you have sort of blockade of these cytokines and inflammatory pathway. So apremilast is the oral PDE4 agent that's been looked at. It's approved, or was approved, I guess, in 2014, as you probably all are aware, for psoriatic arthritis. And the first sort of open label study was only 16 patients that had moderate to severe atopic dermatitis. And they looked at, and I believe they mixed these up, but there was 20 milligrams twice a day for 3 months, which I think should be the circles, although they marked it here as the squares, or 30 milligrams twice a day for 6 months. And they measured, the outcome measure was this EASI score, so improvement or reduction in the EASI score. And you see in the 20 milligram group, there was 19%, the 30 milligram group sort of 30 or 39%. So this was kind of like a proof of concept study. The most common side effects were GI, nausea, diarrhea. There was another study that also was very small, only had 10 patients, and they received 20 milligrams of apremilast twice daily for 12 weeks. And when you looked at the patients that achieved the EASI 75, it was 10%, and another 10% on top of that achieved EASI 50. So a total of 20%, and also 20% had improvement by at least 2 points in their IGA. So the sort of global assessment. The large study that Dr. Silverberg talked about that sort of, in a way, ended maybe some of the enthusiasm in apremilast was the bigger double-blind placebo-controlled study, which was 185 patients. And I think he basically had this exact slide, but just to break it down, it was the when you looked at the mean % change in the EASI score at 12 weeks, there was a 30 milligram BID or a 40 milligram BID. And the changes were 11% in the placebo, 25 and 32% in the treatment arms. And then looking at the secondary endpoints, many of these had very little to no change. This is the itch, the NRS, and wasn't significant, any of these endpoints. Looking at the sort of severe and serious side effects, there were a lot of kind of drug-related side effects when you look at the number of patients. Not a lot were severe. We already touched on some of these, but some of the other ones that we didn't touch on are the infections that Dr. Silverberg touched on. So cellulitis, pneumonia. So it's considered, minimally immunosuppressive. And there seems to be this sort of narrow therapeutic window for these drugs. So I'm not sure where this is going to go. They're used in other diseases. We're still sort of working out some of the nuances, but there are some investigations in the PDE4 inhibition. The major pathway, and you probably have already seen this slide multiple times today, are the JAK inhibitors. So these is a ligand-driven, cytokine-driven pathway where the cytokine binds to the receptor, and then you have JAK receptor phosphorylation, and then phosphorylation STAT can bind, and then JAK phosphorylates STAT, and then you have these downstream inflammatory pathway that's dependent on two things. One, the cytokine, and two, which one of these JAK receptors are involved. So there's 4 different receptors, JAK1, 2, 3, and TYK2. Interesting, in psoriasis and alopecia areata, it appears that there's only one of these pathways involved in the pathogenesis, but in atopic dermatitis, whether it's in acute lesions or chronic lesions, all 4 of these seem involved. So it seems to be a very opportunistic target, and that's why you've seen some of these inhibitors will inhibit different JAKs, so JAK1 or 3 or JAK2. We know that the downstream pathways of the JAK-STAT pathway increase sort of Th2 signaling. So blocking the pathway, obviously in the end, we're hoping that we can block the Th2 pathway. There's 4 different sort of major JAK inhibitors now in phase 2 clinical trials for atopic dermatitis. There's the BARICITINIB, there's oral, and we touched on earlier, topical TOFACITINIB, PF0496582, which is a JAK1, and the ABT494, which is also a JAK1. So the first one we'll look at is the BARICITINIB, and there was a phase 2 double-blind placebo-controlled multi-dose study. This is, as we mentioned, a JAK1 and JAK2 inhibitor. It's approved for rheumatoid arthritis in Europe and other countries, and it's currently, as we mentioned, in phase 2 here. It was a 16-week study, and one of the outcome measures we see here is the EASI 50. So this is the EASI 50 at 16 weeks. There were 2 doses, the 2 milligram and 4 milligram. And as you see here, they also were on topical corticosteroids. And then, just to orient you, these are the weeks. So at week 1, 4, 8, and 12. And we see as early as week 4, we have significant improvement in the EASI 50 with both doses. And this seems to be sustained throughout the whole 16 weeks. This is looking at the change in the EASI score over time. And once again, you see that this, as early as week 1, there was a significant signal. And it continued to improve all the way to week 4 and then was sort of sustained throughout. Sort of the same story with the EASI 75, just not quite as many. So, at the end and as early as 4 to 8 weeks, there's something like 30%-ish patients achieved EASI 75. in both treatment arms. When you look at this sort of magical IGA that I guess the FDA is using as their standard outcome measure, these are the percent of patients that achieve the IGA of 0 or 1. So 0 to 1 is clear or almost clear. And once again, there's as early as 4 weeks we have a signal in the 4 milligram group, not in the lower dose. And by 16 weeks we have as many as 20% of patients achieving an IGA of 0 or 1. This is the SCORAD score, and once again, it's kind of the same response. By 4 weeks, we sort of plateaued out, but has a significant change. We had a significant decrease by 1 week that continued to 4 and then was sustained throughout. And this is looking at itch and sleep. And then the POEM, which is more of a patient-oriented eczema score, similar results. So fairly quick onset. By some of these things as early as 1 week, we have a significant response. Definitely by a month, which I think is good. So then you should know who your sort of responders are and your non-responders are, and these were sustained. So the big thing is, what side effects are we dealing with here? And baricitinib, some of you may know, has been evaluated, I believe, for rheumatoid arthritis and was pulled because of PEs. So, I was curious to see if thrombosis is a factor with these medications. There's quite a few, maybe, adverse events. Not a lot that are serious or severe, thankfully. Obviously, no death, or we might not be talking about these. The most common side effects, headache, blood creatinine phosphokinase increase, nasopharyngitis, cellulitis, lymphopenia. So immunosuppressive, basically, for the most part. Interesting, there was no conjunctivitis and no herpes. So in the tofacitinib world of RA, most centers, including I'm pretty sure our rheumatology center, herpes is a huge concern. And going prior to any tofacitinib initiation, they make sure that everybody's vaccinated. But there didn't seem to be, at least in this baricitinib study. Tofacitinib, Dr. Silverberg mentioned this study. It's just there's only been one sort of small study that I'm aware of. It was 6 consecutive patients with moderate to severe atopic dermatitis. They were placed on 5 milligrams BID of tofacitinib, and then patient 3 actually just received it once a day. And these are improvements in the SCORAD scores over time. This is over 29 weeks. So for the most part, obviously everybody seemed to improve, maybe not as a dramatic improvement as we saw in baricitinib, but further studies are needed. The PF04965842, which is a JAK1 inhibitor. Do they have a name for this one? No? I didn't see any name. There was a 12-week phase 2 randomized double-blind placebo-controlled study where all the patients were adults that had moderate to severe atopic dermatitis and had to have inadequate response or intolerance to topical treatments. And they were randomized into 10 milligrams, 30 milligrams, 100 milligrams, 200 milligrams, or placebo. So this is once a day, unlike some of the other ones. And the primary endpoint was this IGA of clear, 0, or almost clear. And as you see here, this is the placebo, the 10, the 30, the 100, and the 200 milligram once daily doses. And here's the percents, and these are the percent of patients that achieve that IGA of 0 or 1. And as you see, the 100 and the 200 reach significance with 45% of the 200 milligram group achieving clear to almost clear skin. When you look at some of the other outcomes, this is just the percent of patients that responded on a linear scale, and this is change in the EASI score. It's fairly similar type of curve that we saw with baricitinib, where by 4-ish weeks, for sure by 6 weeks, most of the patients that are going to have benefited, and this is sort of sustained throughout the treatment. This is looking at that NRS, so the itch. So this is a big thing with our patients, and multiple other talks have focused on improving the itch in these patients. So this is improvement in that numeric rating scale, which is the itch scale that's being used in a lot of these clinical trials. So this is over the percent of patients that improved, and this is this window, which is the first 14 days blown up. And these are the different dosings. So the blue is the 200. And as you see, this became significant as early as day 2, improvement in the itch, and continued to improve for the first 2 weeks. The side effects of this medication, there was quite a few sort of side effects, not a lot that were serious or severe. You see here 3 to 5%. Looking at what those were, breaking those down by which group it was in. This in the 200 group, there was pneumonia and PE. So I think that's still one of the big concerns of these things, is how immunosuppressive are they? Now keep in mind, when we're considering these medications, obviously you're considering them next to some other likely immunosuppressive agents like cyclosporin or methotrexate. So maybe this profile isn't all bad compared to those. The last JAK inhibitor, the ABT-494, there's an ongoing 88-week phase 2 trial, and these patients in the first period were randomized into the 7.5 milligram once a day, 15, 30, or placebo. And then there's going to be a period 2 that follows, that's a 72-week withdrawal and then rescue period. And the inclusion and exclusion criteria, just for time purposes, I'll kind of just skim through, but it's the same as sort of adults, patients that hadn't been on any other JAK inhibitors, hadn't been on dupilumab. And this is the key sort of efficacy outcomes at week 16. So when you look at percent improvement in the EASI score, in the 30 milligram group, there's 75%. And this seems to be some type of dose response. Same thing with this EASI 75 and 90, which seemed pretty good and sort of on the same range, I think, as dupilumab maybe. Patients that achieved an IGA of clear or almost clear, 50% in the 30 milligram group. And then this is that NRS score that they're all using, the itch scale. And these are the percent of patients that achieved an NRS of 0 or 1. And at 16 weeks, as many as 70% of the patients in the 30 milligram group. So these are promising drugs. They seem to work quick. In the big picture of everything, they seem to be at least as safe, if not maybe safer than some of the alternatives. The current recommendations are, obviously because of immunosuppressive properties, to make sure all the patients are up to date on their vaccines, specifically live vaccines, and specifically probably herpes because of the TOFACITINIB literature that we have. The other thing is, sort of the typical baseline labs, CBC, liver enzymes, and then obviously monitor patients for signs of infection. This is a really good table, and not all of these JAK inhibitors have been looked at in atopic dermatitis, but this paper focuses specifically just on the safety of these JAK inhibitors. And the take-home theme of this paper is basically that these are all pretty equally efficacious. The signal that's different in all of these seems to be the side effects and seems to be the safety profiles. So as you see here, some of these decrease NK cell numbers, some don't. All decrease neutrophil numbers, some don't. There's variable effect on hemoglobin, variable effect on some of these other endpoints. So if you're interested, I encourage you to read this paper because it really does a really good job of comparing sort of the side effects and mean change, sort of laboratory changes in these different JAK inhibitors. Just going to spend 1 minute on these last two. There's not a lot out there. The first one is this SHP1 activator. So it's an SH2 containing inositol 5-phosphatase activator. And it works on the PI3 kinase pathway to affect cellular inflammation. So activation of SHP1 then downregulates the PI3 kinase pathway. And there's been, as far as I know, there's one sort of study on this. They're currently looking at it. There hasn't been any data out. And interesting, they've looked at it in asthma and sort of other allergic diseases with not a lot of promise. But I just wanted you to be aware in case if you run across this in the future. And then the last one is the chemoattractant receptor homologous molecule expressed on Th2 cells, or the CRTH2 molecules that work through prostaglandin D2. So they bind to prostaglandin D2 and sort of inhibit its effects on Th2 signaling. And there's multiple different studies looking at these different agents, most of them with inferior results to the other things we've heard about today, including JAK inhibitors. This one, fevipiprant, there's 450 gram daily, and its mean change in the EASI score was only 8. So as you can see, much lower than what we've seen in even the PDE4 inhibitors or the JAK inhibitors. So in summary, these small molecules, they're definitely coming. Seems that the JAK inhibitors seem to be the sort of leaders and heading very near to the finish line. There's quite a few side effects, although most of them don't seem severe and maybe seem on the same plane as some of the other things that you would be using as alternatives. Probably the immunosuppression, the herpes, and possibly thrombosis might be the big things to look out for, but there's still some things that need worked out. And then finally, there's future targets, whether the SHP1 activators, CRTH2, and I'm sure there's probably a bunch more being looked at. So there's a lot of things coming, I think. It's an exciting time. There's a long time there was really nothing, so I think there's going to be a lot of things coming beyond what Dr. Tameki had as the first lines that's sort of been out for years, and keep your ears open because it's happening fast.